We will now have Mr. S.M. Vijayanand, who is a trustee with the Banyan and former Chief Secretary to the Government of Kerala. Mr. Vijayanand is also a member of CAG's Joint Task Force Social Audit Consultation. In the past, he has served as the Secretary, Ministry of Panchayati Raj, Government of India, Additional Secretary, Ministry of Rural Development, Government of India, among various other positions. Mr. Vijayanand remains active post-retirement as a member of the governing body of leading NGOs. And today with us at the conference, he will be offering a session on reflections and learnings from the palliative care movement in Kerala.
Thank you. I'll try to draw some lessons from Kerala's palliative care experience. I've been associated with it from the day it was operationalized in government. So based on my understanding, in fact, that relationship only made me almost compel Dr. Vandana to become a trustee of Palliative India. And so she now understands both. So it's a time-tested thing. It's about 34 years old. And validated by experience, well studied, with a lot of accolades, including from The Economist and Lancet Commission recently as an ideal model for a developing country. And it moved from classroom to practice to theory again. So it's been doing all the churning. And Kerala is moving up the learning curve. So there are a lot of lessons learned. Like the second policy, I thought I was involved actually in drafting it, like coordinating the group which drafted it. I thought we have reached a very good policy, but it had not anticipated an event like COVID. So now that chapter, in a disaster, what do you do for palliative care, is something which needs to be added. Now, when you look at similarities between mental health and palliative care, of course, need for care and compassion, and joined up effort by the family, the community, civil society, and the state is very obvious. But there are dissimilarities, which you understand better, because in palliative care, sympathy comes very naturally. It moves from pity to sympathy automatically. But will it work in terms of mental health? When you go to the ordinary village, there's a lot of stigma, a lot of fear, and a lot of denial on both sides. So it's not very similar. Whereas in palliative care, the persons are very passive. Here they may not be passive. So some challenges, and the range of affliction, identification and detection, which in palliative care is fairly easy. And of course, they are mostly care. Here we require therapy also. So you know the differences. I'm not getting into it. But important learnings are there. First is the way it evolved. And the way it is evolving, mental health is evolving, there are a lot of similarities and we can latch on to it. It started in the Medical College Hospital, Calicut, by Dr. Rajagopal, along with his assistant, who is Dr. Suresh. He himself is a very senior person now. And they tried it out from the hospital as a local extension in and around that area. Very low-key, small, but a good kind of extension work, local outreach. But the focus was on the community. It was never a doctor-driven model. They went to the community, got volunteers, trained them, reached out to patients, and did this work. And civil society involvement started very early. But basically labor of love, here and there, nothing very systematic or formal. But through this trial and error, they developed the protocols and processes fairly clearly. And with some, you can even call it well validated. Then at this time, I think it was 2008 or 9, at the instance of basically, by the time Dr. Rajagopal left service and started Palliative India, an NGO in Trivandrum. I happen to be a trustee of Palliative India also. So they came out, they helped government draft a policy. But independently, some local governments, basically the village local governments, in India you have a urban local government, a village local government, they are called panchayats and municipalities. So the village local governments in and around Calicut, now it's called Kozhikode, they started experimenting. They wanted to do it. So again, the social capital part which was mentioned in the morning came out. And I must openly say, it is directly linked to religion. It's a Muslim area. They wanted to do something naturally first. And I went and saw it, I couldn't believe it that people can be so altruistic. From high-end societies, boys and girls going to poor households for 2 hours, 3 hours. Later it became long friendship, which is very relevant for us. Friendship with the person. And they started it. And then they said, we want to bring it under the framework of decentralized planning. So we brainstormed. All this didn't take long. After the policy, it would have taken 2-3 months. Based on whatever is happening, that is a bureaucratic skill we have, piecing together a kind of a program, which would be process intensive, which uses public funds, basically panchayats funds. Panchayats are well endowed financially in Kerala. So that started it, and then the practice by local governments. So we saw it, it spread very fast, nobody expected it, unexpected. All the local governments, all the panchayats and municipalities employed a nurse using their funds. So, surprisingly, it was initiated by them. This was followed by NHM supporting the state government after 2-3 years, after the panchayat started. So, that again is a big lesson for mental health. It starts from below, need not wait for the health department to start. And health department will follow suit. That's a big lesson. They can't keep away when some viable model has been developed and there is some kind of interest in this. Initially, that again, I think for mental health, that is a greater relevance. We use the self-help group network of Kudumbashree. Kudumbashree is now a household name in India, as the network in Kerala is called. Fortunately, India has nearly 10 million SHGs now. So we can use them. And in mental health, it's much more direct involvement. Here, because we didn't have any community outreach, we used the SHGs in the beginning. Then it got integrated in the primary health system and all that. And continuous capacity building was done very silently by Palliative India, who trained doctors and who trained these people. But what surprised me was the interest shown by political parties. Not for policy, for directly doing it. So Kerala must be the only state where parties do palliative care. At least 2-3 parties I know. The Communist Party, the Marxist Party does it in a big way in their district. They have a palliative care wing. I was very surprised. Most of these people cannot vote, and their families also may not vote, but I have not been able to study. You are experts in that. Why should a political party be interested? That has a lot of lessons for mental health. We say there will be no political interest. There could be from a different route a political interest. Not all political parties, we think they are all bad and they have some different motives. There is something inside. If we can test that, it will be a better support than anything else. That's a big lesson. But of course, there are a lot of regional variations. It's done very well north-south and rural-urban. Even now, after Kerala has reached a very high level, urban palliative care is not as good as this. It has something to do with the nature of municipal governance and a village panchayat governance. Panchayat is much more governance, and village, the municipality, the bigger the city, more distant it is from the ordinary people. Then, of course, it is very good service delivery. There is a palliative care nurse, and the JPH and ASHA worker, seamlessly, they conduct house visits at least once a month. I don't think anywhere you can have somebody visiting your house once a month or more frequently as per need. It's done systematically, and there are about 160,000 registered patients. Now there's a classification going on, bed-bound, home-bound, like that, so that you can prepare a plan for them. Medicines and comfort aids are given by the panchayat, and clear procedures, they prepare a plan. Food is given normally by the NGOs. So donors give the food and psychosocial support. The panchayat doesn't give, mostly doesn't give. So that neat sharing of responsibilities has fallen into place. Food and other things who need, not all of them need food, is given by the community, not exactly by CSOs, organized CSOs, local clubs, local people, they donate and continuously give them. Then, of course, the psychosocial support is also provided by them. The professional support is provided by government doctors, plus those like Palliative India who are much more specialized in this. And there are former local government plans. So you go to any panchayat, you'll have a palliative care plan, which means you can see what they're going to do in a year, of course, subject to their thing. And there are a lot of committees at the local level, ward level, at the panchayat level. Now, based on 10 years of doing it, the policy was revised. I'd sent a copy of the policy and the action plan to Banyan. I think it can be shared online with you. It's worth going through. All the experiences we tried to put together, and an interesting technique from a bureaucratic point of view. Most policies remain on paper, particularly in our country. But we thought it shouldn't remain on paper. So we put one paragraph in the policy. Within 3 months of adoption of this policy, an expert group will prepare an action plan. Of course, COVID came and 3 months became 3 or 4 years. And there is a substantial action plan. An action plan, those in government would know, is issued as a government order, which means nobody needs to wait. Of course, funding is there. Subject to availability of funds, you can go ahead and practice. So what are the comfort devices? What are the essential drugs? What are the ethical contexts? All these things have come. And then certain standards of training. Who should be trained for how many days? An interesting feature of this, which is very relevant for mental health, the caregivers. Not those who are from outside, home-based caregivers. What training should they give? What support they should get? And all that has been featured. Very clearly it does. And the planning procedure. Kerala is known for its participatory planning from below. So I was very fascinated when all of you described your multi-country kind of planning exercise. Here, the participatory plan calls for a neighborhood network, which is now formed maybe in one third of the local governments. Kerala is not a very big state. It's 34 million population. It's not too small either. So the neighborhood network of palliative care is formed. And the idea is you start preparing a plan from the individual household. What needs you have. I can't replicate it exactly in mental health, I know. But a similar kind of thing. What are your needs and other things, and do it. And then the ambition is that every palliative care patient will have one home-based, in most relative or family member as a caregiver, and one external caregiver who is a volunteer from the community, from the neighborhood, who will go maybe just talk, not exactly do this. Then, of course, this policy has a lot of this thing on citizen education, including students, gradually give them this thing, all kinds of citizen education. But a very important point is livelihoods for the families. Most of the palliative care patients themselves cannot do anything, but their family should be brought under livelihoods program, which are aplenty in Kerala. And then moving up to secondary and tertiary. Now, doctors don't know much about palliative care. They're not taught, except in cancer care very briefly. So idea is, government has agreed, is part of the policy, that within 3-4 years, they will incorporate it into the curriculum for nurses and this thing. Dr. Sanjeev Jain was saying we should do it for mental health also. So you get it into the curriculum, students learn right from the beginning, not as a kind of general knowledge. It's a half a paper or whatever it is. That is again a big this thing. And the ambition is to have an institute for palliative care at the end of 5 years, so that we can share all our learnings and make it a little more formal. And this continuum of care, right from home up to the tertiary, is put. Now, what are the lessons? How do you influence policy? I think, having been a policymaker for a very, very long time, you have a performing model. Most people are worried what will happen to an announced program. Once you have that, greater possibility, which is being nurtured in a real life situation, and which touches some part of your brain or heart, then it's greater acceptance of a policy getting accepted. Second is strategic allies. Banyan has a good number of them. And local upwards. Let's not go. It's very easy to convince a local politician. For example, there's not much time, so I have only 2-3 minutes. In Kerala, in one of the panchayats, 20 years ago, they did a 100% family survey for their planning. To their shock, they realized there were 60 children meaning right from 3-4 up to 20 years, who were mentally challenged. The panchayat president was shocked beyond words. He was a very active politician. It's a small 25,000 population. He thought he knew every household. Can my panchayat have 50 such people? Then they started taking it as a major issue. And ultimately, they came out with a model of community-based care. That itself is a different topic. And now there are 179 such community-based schools in Kerala. Soon, I think every block will have one. Now, every 2-3 panchayats will have one. Every block already has one. So this is very, very important. And very importantly, you have to align with state-specific policies, implied or explicit. For example, Tamil Nadu, yesterday it was mentioned, talks of Dravidian model. So how is mental health care part of the Dravidian model? Kerala has what is called doorstep delivery, and we call ourselves not a welfare state, a caring state. So what is a caring element in mental health? So all these states, especially southern states, have some social priority. If you can link this, then there will be greater attraction for the politician. Funding can only be through convergence. But interesting thing is mental health is part of the People with Disabilities Act, which means 5% of the funds have to be set apart. We are not watching. So funding is there. So we have two schemes called National Urban Livelihood and Rural Livelihood. Livelihoods can be brought totally under that. And if you have a special project, I'm sure it'll get this thing. Then, of course, it is the results, initial results, which will ensure sustained ownership and all that. The range of roles for CSOs. But I'm now part of several CSOs, but I think I can be open in my criticism. CSOs have too much of ego. Very few cooperation among CSOs. I worked in Government of India for the last 4 years. It's very difficult to get two CSOs to work together. So I tell them, forget ego, have your identity. You don't have to submerge your identity, but if you work together. I saw it after COVID. There was an RCRC, which brought all the NGOs, and they did fantastic work, silently. The Rapid Coalition for Response to COVID. Now, of course, it's renamed itself and still continues, about 100 CSOs. If you can work together, I think we can work wonders. But the question is whether we work together is a major question. So this visibility and results and all those kind of things sets off a positive process. Something which Banyan did, palliative care we did. We should not go all over India. We nurture beacons with effort. And you learn from each other. Seeing is believing, particularly among local kind of thing. We have schools of practice. So let me conclude this proactive outreach. Somebody told me how a panchayat is different from a government. There's a lady panchayat president, almost semi-literate. She told me, in the Bible it says, knock and it shall be opened. He says for most people, and particularly for mental health, they can't knock. So you open the door, there's a poetic word, it's her words. You open the door on hearing the footsteps. So that is good governance, that is proactive governance, and that is something which we can do. So the concept of a caring state. And somehow in this thing I thought public-private partnership I saw in this program. It's not public-private. It is professional, people means the persons, plus the civil society, public, which is government, the panchayat, private comes towards the end. So it's that partnership. Wish you all the best. I'm sure many of you can draw lessons from this thing, applicable anywhere in the country. Thank you.
Thank you very much for that, Mr. Vijayanand. Lots to think about for sure.